Welcome to this Step 2 clinical knowledge review on abnormal uterine bleeding test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for abnormal uterine bleeding and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to re-teach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the reproductive and gynecology sections of first aid and your question bank before or alongside this video. Here is what we will cover in this video. First, we will learn to recognize the high-yield question stems for abnormal uterine bleeding that appear on board exams. Second, we will apply specific test-taking strategies for questions about anovulatory bleeding, fibroids, polyps, and endometrial cancer. Third, we will master the next best step question format for evaluation and management. Before watching, make sure you have reviewed the gynecology and reproductive chapters in first aid and your question bank. This video is about strategy, not re-teaching the whole topic. Our first strategy is the age-based approach. When you see a question stem about abnormal uterine bleeding, the very first thing to do is check the patient's age. In premenopausal women, especially teenagers and perimenopausal patients, the most common cause is anovulatory bleeding. The boards will present irregular, heavy, or prolonged periods and expect you to recognize this pattern. In postmenopausal women, the game changes completely. Any bleeding after menopause is endometrial cancer until proven otherwise. The exam expects you to immediately think about endometrial biopsy or transvaginal ultrasound. This age-based split is the single most important framework for these questions. Strategy 2 is the structural versus hormonal framework. Once you have identified the patient's age, ask yourself whether the bleeding pattern is regular or irregular. Regular but heavy bleeding points towards structural causes like fibroids and polyps. The question stem will often mention a pelvic mass, an enlarged uterus, bulk symptoms, or a focal lesion on ultrasound. Irregular and unpredictable bleeding points toward hormonal or anovulatory causes. Look for clues like obesity, polycystic ovary syndrome, thyroid dysfunction, or recent stress. This distinction helps you quickly narrow down the differential and pick the right next step on the exam. Let us look at the three main stem patterns you will encounter. The anovulatory bleeding stem presents a teenager or perimenopausal woman with irregular heavy periods and no structural abnormality on exam. The boards want you to first rule out pregnancy, then recognize this as anovulatory and consider hormonal management. The fibroid and polyp stem presents a reproductive age woman with heavy but regular cycles and an enlarged or irregular uterus. Here, the next step is imaging, usually transvaginal ultrasound. The endometrial cancer stem is any postmenopausal woman with bleeding, or a premenopausal woman over 45 with risk factors like obesity or unopposed estrogen. The next step is endometrial biopsy. Recognize these three patterns and you will answer most abnormal uterine bleeding questions correctly. Here is our first practice question. Read this stem carefully. A 16-year-old girl presents with 6 months of irregular heavy menstrual bleeding. Periods come every 2 to 8 weeks and last up to 10 days. No pelvic mass, no significant history, and her pregnancy test is negative. What is the most appropriate next step? Take a moment to think about which answer you would choose before we walk through it on the next slide. Let us walk through this answer. Step 1. Spot the pattern. We have a teenager with irregular heavy bleeding, no pelvic mass, and a negative pregnancy test. This is textbook anovulatory bleeding caused by an immature hypothalamic pituitary ovarian axis. Step 2. Apply the rule. In a young patient without red flags, hormonal management with combination oral contraceptive pills is first-line therapy. The pills provide both estrogen and progesterone to regulate the cycle. Step 3. Eliminate the wrong answers. Transvaginal ultrasound is unnecessary when the exam is normal, and the history is classic for anovulation. Endometrial biopsy is not indicated in patients under 45 without risk factors for cancer. Hysteroscopy is invasive and not warranted in this straightforward case. The correct answer is C. Combination oral contraceptive pills. Here is our second practice question. A 35-year-old woman with 2 years of progressively heavier but regular periods. She passes large clots, has urinary frequency, and her pelvic exam shows an enlarged irregular non-tender uterus. Her hemoglobin is low at 9.5. What is the most appropriate next step? Think about what the enlarged irregular uterus is telling you and what you need to do before jumping to treatment. Let us walk through this one. Read the question carefully. The stem gives you classic fibroid clues: regular heavy cycles, enlarged irregular uterus, bulk symptoms, and anemia. Now, why does ultrasound come first? Transvaginal ultrasound is the first-line imaging to confirm the diagnosis and characterize the fibroids. You need to know the size, number, and location before making treatment decisions. Hysterectomy may be appropriate eventually, but it is premature without imaging first. Endometrial biopsy is not the primary concern here because the patient is under 45 with regular cycles and no risk factors for cancer. Iron supplementation alone treats the symptom but not the cause. The correct answer is B, transvaginal ultrasound. Endometrial cancer is one of the most heavily tested topics within abnormal uterine bleeding. The risk factors you need to recognize include obesity, diabetes, hypertension, polycystic ovary syndrome, chronic anovulation, nulliparity, early menarche, late menopause, tamoxifen use, and unopposed estrogen. The boards will cluster several of these together in a stem. For biopsy indications, always biopsy postmenopausal bleeding. For premenopausal women, biopsy when the patient is over 45 with abnormal bleeding, or younger than 45 but with risk factors and failed medical management. Also remember the ultrasound threshold. Endometrial thickness greater than 4 mm in a postmenopausal woman warrants biopsy. This is a very commonly tested cutoff. Here is our third practice question. A 62-year-old postmenopausal woman has vaginal spotting, with risk factors including obesity, type 2 diabetes, and hypertension. Her ultrasound shows thickened endometrium at 8 mm. What should you do next? Notice how many red flags the question has stacked together. Think about what this combination of findings is trying to tell you. Let us break this down. Spot the classic pattern: postmenopausal bleeding plus obesity, diabetes, and hypertension. These are classic endometrial cancer risk factors. The ultrasound confirms thickened endometrium at 8 mm, well above the 4 mm threshold. Know the key distinction. You always need tissue for diagnosis. Repeating the ultrasound in 6 months is dangerous because it delays workup in a high-risk patient. Hormone replacement therapy would actually make things worse if cancer is present. A computed tomography scan is used for staging after a tissue diagnosis, not as the initial step. The correct answer is B, endometrial biopsy. Remember, on the boards, postmenopausal bleeding equals biopsy until proven otherwise. Here is a critical test-taking pearl about the evaluation algorithm. When you see any abnormal uterine bleeding question, follow this stepwise approach. First, always rule out pregnancy. This is the #1 mistake students make on board questions. Second, check basic labs, including a complete blood count for anemia and thyroid function tests. Third, get a transvaginal ultrasound to evaluate for structural causes like fibroids or polyps. Fourth, if the patient is postmenopausal or has risk factors for endometrial cancer, proceed to endometrial biopsy. The boards love testing whether you know the correct sequence. Do not jump ahead. A very common trap answer is endometrial biopsy in a young patient without risk factors, or imaging before ruling out pregnancy. Stick to the algorithm and you will get these questions right. That wraps up our review of abnormal uterine bleeding test-taking strategies. Remember, the key frameworks are: use the age-based approach to split premenopausal from postmenopausal, use the structural versus hormonal framework to narrow your differential, and always follow the stepwise evaluation algorithm. Go back to the gynecology and reproductive chapters in first aid and your question bank and focus on the evaluation approach, fibroid and polyp management, and endometrial cancer risk factors and biopsy indications. For one-on-one tutoring and residency advising, visit roadmaptoresidency.com. Do not forget to like and subscribe so you never miss a new board review video. Good luck on your exam, and we will see you in the next one.